Welcome to the Deep Dive, your shortcut to being genuinely well-informed.
Hmm.
Today we're plunging into a really important topic, how we care for our bones, joints, and muscles. It affects, well, everything, how we move, how we feel.
Absolutely. It's fundamental. And our source today is a comprehensive medical surgical nursing textbook. It gives us a great structure. Our mission really is to pull out the key insights, make it accessible so you get the essentials without getting bogged down in, dense medical text.
Exactly. We want you to get well-informed fast. And we're definitely going to hit some surprising facts, maybe a few aha moments,
Yeah,
like why some bone diseases are called silent. You might not know anything's wrong until, snap, a bone break.
Right. Or even things like how your daily soda intake might be affecting your bones more than you think.
Yeah, that one's interesting. Let's dive in. So, okay, first off, let's get a foundational understanding. The source groups these musculoskeletal issues into a few main areas. We're talking osteoporosis, osteopenia, osteomyelitis, bone tumors, and then some specific problems with hands and feet.
And the big picture here, the common thread through all of these is how they impact three main things. Mobility, just your ability to move, pain, which can range from, a minor ache to really debilitating pain, and perfusion, that's the blood flow getting to the tissues.
Okay.
And these three, they're so interconnected, they really dictate a person's quality of life.
Right. Makes sense. Let's start with osteoporosis, often called the silent thief, right? What is it exactly?
Yeah, it's a chronic disease. Basically, it's about how your body regulates bone cells. Bone loss starts happening faster than bone building. So the result is lower bone density, and that makes bones weaker, much more prone to fractures.
And that silent disease part.
Yeah.
That sounds, well, a bit scary. What does it mean practically?
It means it often creeps up on you. There aren't usually early warning signs like pain. Very often, the first time someone knows they have it is when they break a bone, what we call a fragility fracture. Something from a minor bump or fall, sometimes even just coughing. Yeah. So it really underlines why we can't just wait for symptoms. You need to think about risk factors, screening, be proactive.
Okay, so that's osteoporosis. But you also mentioned osteopenia. Is that like a step before osteoporosis?
Exactly. Think of it as low bone mass, but not quite low enough to be diagnosed as osteoporosis yet. It's that stage where the bone breakdown crew, the osteoclasts, are working a bit faster than the bone building crew, the osteoblasts.
Right.
So density decreases. But the good news is it's often a point where you can still intervene effectively, maybe prevent full-blown osteoporosis.
And osteomalacia, that was mentioned too, but less common here.
Yeah, much less common in the U.S. It's bone loss specifically related to a severe lack of vitamin D. It's basically the adult form of rickets, which affects kids. You might see it after things like gastric surgery that affects absorption, or in people with chronic kidney disease.
Got it. So how is osteoporosis classified? Are there different types we should know about?
Yes, the source points to two main types. There's primary osteoporosis, that's the most common kind. You see it mainly in postmenopausal women because of the drop in estrogen, and also in older men, say 70s and 80s, as testosterone levels go down.
Okay.
Then there's secondary osteoporosis. This time is linked to other things, maybe an underlying medical condition like hyperparathyroidism or long-term use of certain drugs. Corticosteroids are a big one. Or even just being immobile for a long time.
Okay, now this is where it gets really interesting for listeners, I think. The causes this mix of genetics and lifestyle. What are the key factors?
Well, it's fascinating how they interact. Like we said, for women, that estrogen drop after menopause is huge. For men, the testosterone decline after 50. Genetically, it's more prevalent in Caucasian or Asian populations. And family history plays a big role, too. If your parents had it, your risk is higher.
Right, but the modifiable risk factors, this is where people can potentially make a difference. Yeah.
Absolutely. This is the actionable stuff. Things like having a very low body weight or a thin build, experiencing a fracture from a minor incident after age 50, not getting enough calcium and vitamin D consistently, protein deficiency.
Smoking too, right?
Yep, smoking history, high alcohol intake, and not getting enough physical exercise, specifically weight-bearing exercise. And you see the overlap, right? Some of these, like certain drug use or immobility, linked directly back to that secondary osteoporosis.
That's a really important connection. So thinking about prevention, when should people start focusing on bone health? Is it an old person thing?
Definitely not. The source really hammers this home. Teaching should start early. It points out women can actually start losing bone mass as early as their 30s.
Wow, 30s.
Yeah. So thinking about it now, getting enough calcium and D, doing weight-bearing exercises, like An investment in your future structural integrity.
And diet, you mentioned sodas earlier. The source had some surprising details there.
It really did. It specifically mentions that drinking large amounts of carbonated beverages, defined as over 40 ounces a day, puts you at high risk for calcium loss.
40 ounces, that's quite a bit, but maybe not uncommon for some.
Right. And it says this risk applies regardless of age or gender.
Well,
And it's not just carbonation. Excessive caffeine can also cause calcium loss through urine. So the advice is pretty clear. Maybe ease up on the soda and excessive caffeine for your bones' sake.
okay, that's definitely food for thought, or drink for thought. So if someone is concerned about osteoporosis, what does the assessment involve?
Well, physically, a doctor or nurse would look for clues, things like kyphosis, that's the humpbacked curve, any noticeable loss of height, asking about back pain, especially pain that gets worse with activity, or tenderness, which might signal a vertebral compression fracture.
Okay.
Sometimes even GI issues like constipation or reflux or breathing problems can be related if the spine is affected. And the most common fracture sites are the vertebrae, the wrist, and the hip.
What about the psychosocial side? It must have a big impact.
Oh, huge. The assessment looks at body image concerns, anxiety, fear, especially fear of falling isolation, chronic pain leading to insomnia or depression. It can affect self-esteem, relationships. It's really broad.
So for diagnosis, are there specific blood tests?
Interestingly, no single lab test for calcium or vitamin D definitively diagnoses osteoporosis, though they might check those levels as part of the picture. The gold standard, the best tool, is bone densitometry, usually a DXA scan, that's dual X-ray absorptiometry.
DXA scan.
Yeah, it measures your bone mineral density very accurately. Other tools like QCT, which is a type of CT scan, and MRI can also be used.
So all these findings, the assessment clues, how do they translate into a care plan? What are the main concerns?
They point directly to the main challenges, or cues, as the source calls them. Things like risk for falls, definitely, impaired physical mobility, managing pain, whether it's acute or chronic, and overall the potential for fractures. That's what the care team focuses on managing.
Okay, so once it's diagnosed, what interventions come into play?
It's usually a mix of lifestyle changes and often medication. Nutrition-wise, a balanced diet is key, limiting that alcohol and caffeine we talked about.
And exercise.
Crucial. Strengthening exercises, maintaining range of motion ROM, and importantly, weight-bearing activities. Things like walking, jogging, dancing. Other lifestyle things include quitting smoking, if you smoke, and making the home environment safer to prevent falls. Then there's drug therapy. Often starts with calcium and vitamin D supplements just to boost what you get from diet.
Right.
Important point here. It's best to take them in divided doses through the day with food and plenty of water, like 6 to 8 ounces, to help prevent kidney stones. You'll see common brands like Citrical or Oscal over the counter.
And what about the prescription drugs? Bisphosphonates seem like a big category.
They are very common. Their main job, their mechanism of action, is to slow down bone resorption. That's the breakdown process. So they help preserve the bone you have.
Do they have side effects?
They can. GI upset is pretty common, sometimes irritation or even ulcers in the esophagus or stomach. That's why how you take them is so important. The instructions are very specific. Take it on an empty stomach, first thing in the morning, with a full glass of water.
Okay.
And then you have to stay sitting or standing upright for at least 30 minutes. No lying down. That helps prevent that irritation.
Got it. Any examples?
Sure. Common oral ones are alendronate, brand name Fosamax Ristronate, which is Actonel, Ibandronate, Boniva. There are also IV versions like pamidronate and zoledronic acid. And a really critical point the source mentions, with some bisphosphonates, especially the IV ones, there's a suspected, though rare, risk of osteonecrosis of the jaw, basically, jawbone death.
Wow, okay, that's serious. Good to know.
Yeah.
What about other hormonal approaches?
Yeah, there are others. We have estrogen agonists, antagonists like raloxifene. These are clever. They sort of mimic estrogen's good effects on bone, helping preserve density, but block its effects elsewhere, like in the breast tissue. Potential side effects to watch for are blood clots, DVT, and possibly affecting liver function tests, LFTs. Other options include calcitonin, which is a thyroid hormone that slows down the bone breakdown cells, parathyroid hormone, which counterintuitively can actually be used in specific ways to build bone in high-risk women. And then there's denosumab, or Prolia, that's a different type, a RNKL inhibitor, often used if other treatments don't work well. It's an injection given twice a year.
Okay, quite a range of options there. Let's shift gears now to osteomyelitis. Sounds quite different in infection, right?
Yes, completely different beast. Osteomyelitis is an infection in the bone tissue itself. The source describes this whole cascade. A pathogen gets in, usually bacteria like staph, sometimes MRSA, that tough-to-treat kind.
Right.
That triggers inflammation, swelling, more blood flow initially. But then the swelling can cause tiny blood clots in the bone's vessels. This actually reduces blood flow to the bone, leading to bone tissue dying off. That's necrosis. It forms something called a sequestrum, a piece of dead bone. And this can lead to an abscess, a pocket of infection, sometimes spreading further. Viruses and fungi can cause it too, but bacteria are the usual culprits.
So how does the infection actually get into the bone? What are the routes?
Good question. There are a few ways. It can be exogenous, meaning from outside. Think of an open fracture where the bone breaks the skin, allowing germs in.
Okay.
It can be endogenous, carried through the bloodstream from somewhere else inside the body, maybe a UTI or an infected IV line or even a gut infection.
Oh.
Or it can be contiguous, spreading directly from nearby tissue, like a bad skin infection right over the bone, or even an infection in the mouth spreading to the jaw. And it can show up as acute, sudden, severe, or chronic, meaning it lingers or keeps coming back.
And the symptoms are different for acute versus chronic.
Yes, quite different. For acute osteomyelitis, think classic signs of infection. Fever, usually over 101 Fahrenheit, localized swelling, tenderness, redness, erythema, and warmth around the area. The bone pain is typically constant, deep, and localized right over the infected spot. Sometimes the skin might break down, forming an ulcer. Lab-wise, you'd expect high white blood cell counts, a high sedimentation rate, and maybe positive blood cultures if bacteria have spread into the blood. Bone scans or MRI usually confirm it.
And chronic.
Chronic looks different. Often you see persistent skin ulceration, very commonly on the foot. You might see a sinus tract that's like a little tunnel draining pus from the infected bone out to the skin surface. The pain is usually localized, and there's often drainage.
Yikes. Given how serious this sounds, how is it treated?
Treatment has to be aggressive. It usually starts with high-dose IV antibiotics, often for weeks, sometimes followed by months of oral antibiotics. Wound care is also key irrigations to clean the area. Pain management is essential. Sometimes they use hyperbaric oxygen therapy, breathing pure oxygen in a pressurized chamber to help boost healing and fight infection.
Does surgery ever come into it?
Often, yes. Especially if there's dead bone, that sequestrum we mentioned. Surgery called a sequestrectomy might be needed to remove it. In bad cases, they might need more complex surgery like microvascular bone transfers, basically transplanting healthy bone with its blood supply. And the source makes a really critical point. Sometimes antibiotics and standard wound care just aren't enough. Surgical debridement, cleaning out all the infected tissue becomes necessary.
Makes sense.
And post-surgery care is intense. Constant monitoring of the limb's neurovascular status is vital. We use the 6Ps checklist.
The 6Ps.
Yeah. Pain, especially pain that seems way worse than expected. Paresis or paralysis, any weakness or inability to move. Paresthesia, that pins and needles feeling or numbness. Pallor of the skin, looking pale or white. And pulselessness, can't feel a pulse.
Okay.
Any of those keys are an emergency. You report them immediately because it could mean nerve damage or loss of blood supply. Nursing care also focuses on pain, fever, making sure tissue perfusion is okay, and watching closely for sepsis or septic shock, which are huge risks.
Okay, that sounds incredibly serious. Let's shift now to bone tumors. What's the main difference between benign and malignant?
So benign bone tumors are non-cancerous. The key thing is they don't spread. Often they cause no symptoms at all. They might just get picked up on an x-ray done for something else. Or sometimes they weaken the bone enough to cause a pathologic fracture or break that happens because the bone was already weak. The cause is often unknown. If they do cause symptoms, it's usually localized pain, maybe some swelling or muscle wasting around the area. Diagnosis is usually x-ray, maybe MRI treatment. Often just watching it, maybe NSAIDs for pain, or surgery to remove the tumor, possibly with bone grafting.
And malignant bone cancer.
That's different, definitely more serious. We talk about primary bone cancer that starts in the bone. This is actually more common in younger people, like teens and young adults.
Oh, interesting.
Then there's secondary bone cancer. This is much more common overall, especially in older adults. This is cancer that started somewhere else, lung, breast, prostate, wherever, and then spread, metastasized to the bone.
Okay, and symptoms.
Often similar to benign tumors, but maybe more persistent or severe. Pain, swelling, maybe a noticeable tender lump or mass.
How is bone cancer generally treated?
The main approaches are surgery, chemotherapy, and radiation therapy. Often they're used in combination, depending on the cancer type, location, and stage.
And for patients going through this, what are the key nursing care goals?
Managing pain is huge, obviously, whether it's acute or chronic. Helping patients cope with the fear and anxiety that comes with a cancer diagnosis is critical. Supporting them if they're having trouble coping, addressing mobility issues, helping with self-care if they're weak or in pain, and always being vigilant for those pathologic fractures.
Okay, now let's zoom in a bit on some specific disorders of the hands and feet.
Mhm.
Things that might seem smaller scale but can really impact daily life.
Absolutely. Let's start with the hand. One condition is Dupuytren's contracture. This is where the fascia, that layer of tissue under the palm skin, slowly thickens and tightens up. It causes the fingers, usually the ring and little fingers, to curl inward, making it hard to straighten them. It can sometimes affect the feet too, but it's mostly the hand.
Can it be fixed?
Sometimes surgery is needed to release that tight tissue. Post-op care involves things like exercises to regain motion, managing pain similar to carpal tunnel recovery in some ways.
Okay. And common foot problems.
Hmm.
Bunions seem really common.
Very. That's technically called hallux valgus. It's that bony bump at the base of the big toe, making the toe point outwards. Women get it more often than men, possibly linked to footwear choices over time. If it's bad, surgery, a bunionectomy might be an option.
What about hammer toe?
Yeah, hammer toe is where one of the smaller toes gets buckled, bent at the middle joint, kind of like a hammer shape. Can be painful, rub on shoes.
And plantar fasciitis, I hear about that a lot. It sounds painful.
Oh, it can be severe pain. It's inflammation of the plantar fascia, that thick band of tissue on the sole of your foot. Classic symptom is sharp, stabbing pain in the heel, especially with those first steps out of bed in the morning.
Mhm.
Treatment. Usually conservative stuff first.
Uh,
Rest, ice, stretching exercises are really important. Supportive shoes or orthotics, maybe NSAIDs for the inflammation. If it just won't quit, sometimes endoscopic surgery is considered.
and one last one, a ganglion.
Yes, a ganglion cyst. It's just a round, fluid-filled lump, totally benign, often pops up on the wrist or maybe the foot, usually near a joint or tendon. They're kind of weird. They can appear suddenly, disappear just as fast, and then maybe come back later. Generally harmless unless they're pressing on a nerve or causing discomfort.
Well, we have certainly covered a lot of ground in this deep dive,
Right.
from the quiet threat of osteoporosis, the fight against bone infections, understanding tumors, and these everyday hand and foot issues. It really gives you an appreciation for how complex, but also how resilient our musculoskeletal system is. We've touched on bone density, infections, growths, limb-specific stuff.
We really have. And maybe that brings us to a final thought for you, the listener. Considering how much all these conditions affect mobility, quality of life, think about this. What's one, maybe overlooked, aspect of your daily health routine that could significantly help prevent future musculoskeletal problems for you? It could be something small, you know?
Yeah.
But those consistent actions may be related to diet, a specific type of exercise, just a simple lifestyle tweak tied to those modifiable risks we discussed. They can really add up. It's often those small daily habits that make the biggest difference in the long run for your bone and joint health. Something to ponder.
That's a really great thought to end on. Thank you so much for joining us on this deep dive. We hope you feel better informed, maybe a little more empowered, to keep exploring these vital health topics.